Hi, today we will be discussing Chapter 28 of Harrison's Principles of Internal Medicine. This chapter deals with disorders of the eye. This slide set is part 3 of 3 on red or painful eye disorders in this chapter. In this set of slides, we will discuss 6 etiologies, namely herpes zoster, episcleritis, uveitis, posterior uveitis, acute angle closure glaucoma, and endophthalmitis. Herpes zoster results from reactivation of latent varicella virus infection. It causes a dermatomal pattern of painful vesicular dermatitis. Ocular symptoms can occur after zoster eruption in any branch of the trigeminal nerve, but they are particularly common when vesicles form on the nose, reflecting nasociliary or V1 involvement called Hutchinson sign. Herpes zoster ophthalmicus produces corneal dendrites, which can be difficult to distinguish from those seen in herpes simplex. Stromal keratitis, anterior uveitis, raised intraocular pressure, ocular motor nerve palsies, and neuralgia are other common sequelae. Treatment includes antivirals and cycloplegics. In severe cases, glucocorticoids may be added to prevent permanent visual loss from corneal scarring. Episcleritis is the inflammation of the episclera, which is a thin layer of connective tissue between the conjunctiva and the sclera. It resembles conjunctivitis but is a more localized process and discharge is absent. Most cases of episcleritis are idiopathic, but some occur in the setting of autoimmune disease. Scleritis refers to a deeper, more severe inflammatory process that is frequently associated with a connective tissue disease such as rheumatoid arthritis, SLE, polyarteritis nodosa, granulomatosis with polyangiitis, relapsing polychondritis. In anterior scleritis, the globe assumes a violet hue and the patient complains of severe ocular tenderness and pain. With posterior scleritis, the pain and redness may be less marked, but there is often proptosis, choroidal effusion, reduced motility, and visual loss. Episcleritis and scleritis should be treated with NSAIDs. If these agents fail, topical or systemic glucocorticoids may be necessary, especially if an underlying autoimmune process is active. Uveitis, because it involves the anterior structures of the eye, is also called iritis or iridocyclitis. The diagnosis requires slit lamp examination to identify inflammatory cells floating in the aqueous humor or deposited on the corneal endothelium called keratic precipitates. Anterior uveitis may develop in the following conditions. Although anterior uveitis can occur in conjunction with many diseases, no cause is found to explain the majority of cases. Treatment is aimed at reducing inflammation and scarring by judicious use of topical glucocorticoids. Dilatation of the pupil reduces pain and prevents the formation of synecdoche. Posterior uveitis is diagnosed by observing inflammation of vitreous, retina, or choroid on fundus examination. It is more likely than anterior uveitis to be associated with an identifiable systemic disease. and is usually a manifestation of autoimmune diseases, but it also accompanies certain infectious diseases. Glucocorticoids have been the mainstay of treatment for non-infectious uveitis. Monoclonal antibodies, which target pro-inflammatory cytokines, such as the tumor necrosis alpha inhibitor adalimumab, are effective at preventing vision loss in chronic uveitis. Acute angle closure glaucoma is an unusual but frequently misdiagnosed cause of red or painful eye. Asian populations have a particularly higher risk of angle closure glaucoma. Susceptible eyes have a shallow anterior chamber because the eye has either a short axial length, such as in hyperopia, or a lens enlarged by the gradual development of cataract. When the pupil becomes mid-dilated, the peripheral iris blocks aqueous outflow via the anterior chamber angle, and the intraocular pressure rises abruptly, producing pain, injection, corneal edema, obscurations, and blurred vision. The diagnosis is made by measuring the intraocular pressure during an acute attack or by performing gonioscopy, a procedure that allows one to observe a narrow chamber angle with a mirrored contact lens. Treatment includes oral or IV acetazolamide, topical beta blockers, prostaglandin analogs, alpha-2 adrenergic agonists, and pilocarpine to induce miosis. If these measures fail, a laser can be used to create a hole in the peripheral iris to relieve a pupillary block. Endophthalmitis results from bacterial, viral, fungal, or parasitic infection of the internal structures of the eye. It usually results from hematogenous seeding from a remote site. Septic emboli from a diseased heart valve or a dental abscess that lodge in the retinal circulation can give rise to endophthalmitis. Chronically ill, diabetic, or immunosuppressed patients, especially those with a history of indwelling IV catheters or positive blood cultures, are at greatest risk for endogenous endophthalmitis. Although most patients have ocular pain and injection, visual loss is sometimes the only symptom. White-centered retinal hemorrhages, known as Roth's spots, are considered pathognomonic for subacute bacterial endocarditis, but they also appear in leukemia, diabetes, and many other conditions. Endophthalmitis also occurs as a complication of ocular surgery, especially glaucoma filtering, occasionally months or even years after the operation. An occult penetrating foreign body or unrecognized trauma to the globe should be considered in any patient with unexplained intraocular infection or inflammation. This ends part 3 of the slide set for red or painful eye disorders. Next set of slides will deal with eye disorders that cause transient or sudden visual loss.